let the others start to log in. Thanks for coming. I'm just going to hit play on Instagram. And we'll see as it all starts to log in. Always interesting when it's all going off in all different places. So, right, okay. Hi there, John. Good to see you over there. And I think we're away. Right, okay. Hi there, Instagram. We are live for about the next 40, 45 minutes, maybe an hour. It depends. Sometimes these can go on a little bit. Happy New Year to those I haven't seen, spoken to, connected with in the last 6 days we're in now to 2021. And it's interesting, isn't it, how we spent the whole of 2020 thinking, let's get to next year. And then we come into this year and it's lockdown 3. But we are, hi there, Sharon. Good to have you along as well. Yeah, we're back on whenever we do a lockdown. We've been doing every Wednesday, 1 hour at 12 o'clock, live Biomechanics Q&A. And what usually happens is I get questions in advance and I try and put them together to create something that I'm hoping will be interactive as well. It will mean I kind of have to flip between the 3 platforms that I'm on. Facebook is the one that I can't post on. Sorry, guys. Instagram, I can see you, and Zoom, I can see you guys. But anything you post, I can look back at afterwards. So basically, we've got 2 questions today. And if you have not seen any of these lives before, they are all over on the Biomechanics Education YouTube channel. So if you haven't already, I should go and subscribe over there. There is loads of free content. Every single Biomechanics Q&A that we've done since last March, all through each of the lockdowns. They're all up there. They're all around about 45 to an hour in duration, and they're all based on questions that come in from you guys. I get questions asked of me all the time based on, obviously, my social media posts. Predominantly, I am an educator of professionals, but I also get questions coming in from professionals, from their clients, and I also get questions, obviously, from my clients. So I do have a small practice when I am allowed, of course. And there's often a lot of crossover. So those of you who followed me for a while will see that what I'm trying to do is simplify the complex subject of the human body, its biomechanics, the way we move, the problems that we and our clients face. And so by simplifying it for us, quite often it helps clients to appreciate and understand what we're talking about as well. We can get technical in the classroom, I've got no problem with that, but in my experience, it's more helpful when simplified when you're trying to put something into application. So in terms of what does that mean, we can get very complex into the detail, but actually in application, it's really simple. Does the hip flex? Do they rotate? Where does it hurt? So I think there's a nice place in the middle where I enjoy a lot of my communication with both professionals and the clients, actually, and we can kind of meet a little bit in the middle. For today in these lives, I generally do tap between a little bit of technical speak, so if there's any clients, non-fit pros out there, forgive me, you can feel free to ask questions as we go, but I do try and, even with the technical stuff, kind of simplify it back down again. So I've got my friend here to help, and the mascot over in the background. He's grabbed my mat. I was going to do a demo with the first question, but it's nudged me off the mat. So we've still got people logging in, which is great. John, nice to see you. Suzanne, hi, nice to have you along. Just going to check in, see if there's any other questions coming in. Instagram, nice to have you all along. Okay, nothing coming in just yet. So I've got 2 questions. What can often happen is, while it seems, how are you going to fill an hour with 2 questions? They spin off quite a lot, and I've got 2 fantastic questions. One that's very short and one that is longer. The short one should be relatively easy, but the reason I like to discuss them like this is they often help people think about their own questions. One of the biggest things I end up teaching and try and help professionals to understand is, I know that Ben Coombe is a massive fan and advocate of this as well. If you ask a really good question, you will get a really good answer. If your question is ambiguous, and particularly on social media, you're going to get a whole bunch of cognitive biases on how individuals are interpreting what you said. So when you really knuckle down to what you're trying to find out, you can often end up finding the answers yourself anyway. So the first question I've been asked is, why can't some people do the thread the needle move? Now, again, I've got no problem with using kind of names for certain movements. I like to turn it back into, well, what does that look like? Because my interpretation of the thread the needle may differ to yours. So, Marina, if this is not the one that you were asking about, then obviously please correct me. But from my research and what I know of it, the thread the needle move is this one, isn't it, Roxy? So, going into a prone kneeling position and then taking one arm underneath the other one so that you are in this kind of position. I don't know where the rules are on this arm. So the hip is flexed, the knee is flexed, the spine is rotated, and the bottom shoulder is in horizontal flexion. So what I've done there by defining the position to make sure it's the one that Maria was asking about is, she's asking why can't some people do it? So if you analyse the movement in that way, so I'm kneeling, the hips flex to about, well, it goes beyond 90 once you go down into that shoulder position. The spine is rotated, and in that example, to the left, and the shoulder is horizontally flexed, adductive, whatever you want to call it. If some people are struggling, then it's likely that they have areas within each of those joints we've just given the example of that they might want to improve certain substructures. So there's 3 substructures in the body. There's the skeletal system, the myofascial system, so the muscles and the fascia and soft tissue, and then the neural system. So if you're breaking it down into the 3. So if your hip is going beyond 90, then is there something in that hip joint that is limiting the hip flexion component? Is it something within the spine rotation component, or could it be something within the shoulder that is also limiting? Now, the only question I got was exactly that: why can't some people do thread the needle? So I would want to ask Maria a lot more questions. When you say they can't do it, is it because they can't get in the position? Is it because it hurts? Because if it hurts when they're kneeling, it could be something to do with the knees, or aging of the knees, or if they've had any knee surgeries. So that would add something else in there. So I would always take it case by case. But I'm going to assume, I don't like assuming, but I've had to assume in this case, I'm going to assume that Maria just means that when she's teaching her Pilates class, some people just can't get into that position. So if you think about the position again, so in a kneeling position, this is my understanding of it, all fours, and then taking one arm underneath the opposite shoulder. So you can see how much more than 90 degrees has gone at the hip. So that's quite a deep hip flexion angle, combined with about 90 degrees at the hip from the ones I've seen, although I've seen this done in different positions as well. It could potentially be done with less hip flexion. The question I would want to know is, are the hips, do they need some work? Do they need joint mobility, muscle flexibility, or nerve mobility? You can also look at the idea of the rotation in the spine and the shoulder as well, or it could be a combination of these. So what do? Well, we have to then address each joint, try the move again, and then see if it improves. That is movement analysis. That is the way I would benchmark a client's movement quality. We might say, well, why are they doing the thread the needle? Is that not a mobility technique? Well, it is in some respects. They're using up those joint ranges. But if they're limited in one specifically, can we do something else? And can we identify the specific substructure? So because that move is, or that position is made up of several joints being involved, then you are going to be struggling potentially to differentiate unless you have a keen eye or some other way of testing the body. You could do it in the other direction, and if that way is easier, then we might then be able to blame it on higher up the body. But it's going to be different, possibly case by case as well, Marina. So even though there are quite a few people who might be limited by it, there's quite a lot of people out there who have stiff pelvis, stiff thoracic spine, and potentially a combination of these. Could be a result of the joints, the muscles, the nerves, or a combination of them. So it's not a simple solution, but when you break down a movement, I just wanted to go through that with you so you can see how I would try and identify why some people are struggling. I would want to see them individually, and then I would be testing them, but obviously that's not possible. So to help Marina out, I would say, think about the move. Can you break it down? Can you focus on the hips? Can you then focus on the spine alone, the shoulders, and then redo the thread the needle move? And if they improve, fantastic. So I'm not sure if that throws up any more questions. Just based on what I've said in there, just have a quick flick over Instagram. They're just watching over there. So I'm not sure if that brings up any further questions. But I thought that was quite a good kind of basic one. And even a basic question is never a simple response, because I would want to ask so many other questions. Injury history, age, you know, why are they doing it? What they're trying to achieve? What's their daily lifestyle like? Are they, you know, I want to be, how does their thoracic rotation measure? How well do their hips flex extend? So you can be using various benchmarks and tests for each area of the body as well. Put them together, see what happens on the eye of the needle. My understanding is it's a mobility technique. The problem with some mobility techniques is there can be cheat mechanisms within them if you're using multiple joints. Because where it might be, let's say it was, and I don't know this, I'm assuming, again, maybe wrongly so, she's over here, Marina. Would you use the arm for this? Yes, I definitely would, Marina. She's over on Instagram. So if you were taking the threading the needle as a spine rotation technique, brilliant. It does encourage thoracic rotation. One of the problems is some of that rotation could be hidden by a lot of range coming from the shoulder, or if the hip dips. So it looks like someone is actually rotating quite a way across, but actually they've dipped at the back hip, the shoulder's done a lot of that movement, and they're not getting so much rotation from the thoracic spine. So if the goal is to improve thoracic rotation on its own, do thoracic rotation on its own. Fix the hips on a chair, get yourself a pole, and just do thoracic rotation and nothing else. And that way you can really make sure you are improving the rotation of the thoracic spine on its own, so that when you do thread the needle, and you see a response to that, it's improving, fantastic, you know that's a limiter. Aidan Morpheus would like, you want to know more why, are they trying to do that? Yes, I totally. I would perform any assessment to look at it. Yeah, fantastic. So Morpheus over on Instagram is saying, why are they trying to do the movement? What does the individual look like? So Marina, I hope that's helpful. Definitely do some eye move freely. So we're going to be talking about eye move freely because of the next question as well. So I'm just going to pause a moment, let the Zoom guys see if there's any questions over there. See if I can see Facebook team. Leah, Maggie. Oh, brilliant, like it. Claire, they're all over on Facebook, brilliant. So I can't see you all the time, Facebook, but I'll come back to you in a moment. Okay, no questions coming in. Fantastic. Okay, now question number 2 has a lot of sections to it. So this is probably going to take up the bulk of this, and there's an initial basic question which we actually did cover previously, Jackie, on one of the Biomechanics Q&As. I'll see if I can find it for you. But then it's kind of gone through some more elaboration. So what I'm going to do is I'm going to read through it, and then I'm going to address different points within it at the end, if that's okay with you guys. So the original question is posture, to correct or not to correct. So I'm just going to very briefly touch on what we spoke about on, I think it was virtually an entire post Q&A actually. Posture by definition is a body position. So any position you put your body in is a posture. Some are deemed to be bad postures, some are deemed to be good postures. So good posture is deemed to be really nice alignment, shoulders are level, hips are level, knees are the same. And from 30 years teaching Group X classes, to see perfect alignment, real perfect skeletal alignment is actually quite rare. So by definition, posture is simply a position, and good and bad posture, who is really qualified to state what is a good and bad posture? What I mean by that is a bad posture is suggesting that a certain body position is a bad one. I'm not saying there isn't one, but it's keeping an open mind to this. So let's take the most commonly described bad posture, which is the round shouldered position. Yeah. So I'm doing it right now, and now I'm not, and I'm perfectly fine. So I'm now in a bad posture, I'm now in a good posture. So is it really that bad if I can do it and I'm okay? So the real negative aspect of body position is long, sustained, static postures that result in adaptations and compensations that are negatively affecting how we feel and how we move. So you can't really say that a single posture is a bad one unless you stay in it for so long that it negatively affects the way you move or feel. So again, the bad posture example is this one, because most people will spend quite a bit of time in the round shouldered bad posture of sitting. So the actual position itself isn't bad, it's the duration that it's held for, and the fact that the ligaments are held in a stress, the ligaments across the back, so you get this ligamentous creep. That would be made over time, and not even maybe for a day, maybe not even for a week, but over time, months, weeks, and so on. That's where people start to complain of, I've got a stiff neck or a sore back. And that is when the posture has been held for too long, too often, too consistently, possibly resulting in discomfort and adaptations. Good posture, which might be deemed standing nice and tall, can also result in a compensation that has a negative effect on how we feel and move. So if you are permanently standing in an upright position, that's going to, over time, be quite hard work. And so the muscles might fatigue. Dancers, you have to hold postures upright. That's quite hard work. That's the bodies are under stress for a long period of time. Military guys who are, in their sort of marching positions and postures. So good and bad posture, we need to understand what that means first. Posture by definition is just a body position. Bad postures are probably the ones we hold for too long, consistently or over time, that then result in a negative effect, compensation or adaptation to the way we move or the way we feel. So I hope that clears that part up first of all. And then it's then, well, what do postures that we hold for too long or so on, how can that affect us? So I'm just going to go into the rest of this question so we can understand in a bit more detail why this question has been asked by a friend of mine. So, diagnosed with a hip impingement. So that changes now the focus. Posture and a clinical issue starts to make things slightly different. If you have an injury like a hip impingement, and again, this allows me to elaborate on things that are biomechanical and things that are medical. So things like a hip impingement can happen more likely from a biomechanical issue that has then resulted in what has been diagnosed as a medical issue. Because over time, the postures being held, or from this individual's very active lifestyle, for example, maybe the way carrying the bag on the same side, lifestyle is very asymmetrical, has resulted in a wearing or an impingement or something changing within one side of the body of the pelvis. The hip impingement is likely to cause a shift as weight transfers just even in walking. Because if something hurts or it's uncomfortable, or even when we're jumping or landing, when we're teaching classes, we can subconsciously, even though we feel like we're landing the same, we can subconsciously shift our weight. This can then result in biomechanical asymmetries, and so it's like, which comes first? Injuries, by definition, are really when somebody has trauma. So what I mean by that is a car accident, you fall off your bike, you trip over a step, and you bang and break something. Most common types of things that are classified as injuries, I don't classify as an injury, I would classify as a biomechanical loading that can, over time, result in a wearing issue that becomes a medical issue. So I think that hip impingement here, unless this individual's had an accident, hip impingement, in my understanding, is something that happens over time from wearing or asymmetries, from adaptations, maybe from a posture that's been held for a long time, or carrying a bag on one side. All of this is hypothesis. This is very difficult to track and trace, to use the vocabulary there, because it's all in the past, it's all in the history. So we can look back and say, well, yeah, I drive an automatic car, I'm always using that one pedal, I carry a bag on one side, I favour an arm in my sport. All of these things can contribute to asymmetries in our intrinsic posture. So the hip impingement starts to give us the impression that the individual is uncomfortable. So that adds into, okay, that's something we need to keep in mind. Diagnosed with an anterior pelvis tilt. This is another subject that we covered. An anterior tilt of the pelvis is not a diagnosis. It is a position of the pelvis. So an anterior tilt is this one, a posterior tilt is this one, and a neutral is somewhere in the middle. Yeah. So an anterior tilt, like posture, it shouldn't be given as a diagnosis. It often is by therapists and physios in this case, and that's not necessarily wrong. I guess it's wrong when you know a little bit more and you want to know, well, what does that mean? And I think quite often clinicians or medical professionals will give us lay language because either the medical language they feel might be too complex, or they're not actually 100% sure what is causing it. They just know your position of your pelvis is this one. And if your back is sore, the assumption that is why you have a sore back. I'm not saying it isn't, but it's all based on hypotheses. But an anterior tilt in itself shouldn't be the diagnosis. It's just a pelvic position. I do hear about this very commonly, that people are given a diagnosis of an anterior pelvic tilt. But where I'm going to get to at the end of this ultimately is we need to understand, well, what does that mean? Why do you think that? Why is that a problem? What's wrong with that position of the pelvis? So we'd want to go into more detail. This individual was told that the right hip was higher than the left, resulting in a mild scoliosis. So what we could deem here is the mild scoliosis is actually caused by the asymmetry in the pelvis. So maybe the scoliosis is a causative result of dysfunction around the pelvic area from the impingement, the shift in the weight, and so all of this is starting to result in these other things happening. I have no idea, by the way. I'm just taking what I've been given and talking it through, which is what I would do with this individual. I'd want to understand more. I'd also want to speak to the physio or the therapist who's given these diagnoses, so I can understand better how they tested this, what they think is going on, and so we can then marry up our thinking to get to a better position of what we can do about this. Pain is always in the right hip and the lower back. So if the right hip is the one that is the impinged, that would give the reason as to why that one hurts. Lower back, well, if you are taking the weight off it and you're getting that little bit of scoliosis, then that could result in one side of the spine sort of hinging, so QL muscle can get compounded, and so that can make it grumble and it says, oh, I don't like this. So pain is a good thing. Pain is telling you need to change something. And I know we kind of always think of it negatively. You can focus on, right, my body is trying to tell me something. I'm uncomfortable. Why am I uncomfortable? And trying to always look above and below the area that hurts, because that's usually where the force is coming from. Just going to carry on reading through. So should I try and correct the posture, level up the hips, adjust the tilt? And the physio has said, just try and stand normally. Now, I'm assuming that normally here means level and straight based on the rest of the question. The normal here for this individual feels very, the normal is actually wonky. So it's this kind of like tilt and the scoliosis in the spine, and what others would deem as a bad posture. When trying to align myself, the pain goes into the right QL. So again, that would be where taking the pressure off that right hip that's impinged results in QL kind of getting squished. A right hip flexors at the front, muscles on the right side of the back in a state of contraction. Yeah, TFL IT band on fire. If I stand in wonky normal, no pain, but if trying to be straight, it's uncomfortable. But she also talks about being able to do a standing tuck jump, so where both knees come up, is not a problem, almost with surprise. Am I making myself worse by tentatively trying to align myself and pushing my body where it doesn't want to go? Possibly. Been doing static stretching, but that wasn't helping, and so now has been given balance work. And this is where I want to sort of come down to now is, with all of that in mind, what didn't work and what is working. So very often when people have pain, discomfort and problems, there's this instinct to go straight into strength work. The assumption is the pain is caused by something being weak. So we then look at the definition of weak, and weak doesn't mean strengthen, although in our industry, if someone's weak, strengthen it. What we need to understand is what is causing the weakness to address that prior to doing the strength work. So what I mean by that is exactly what the physio has now done with this individual is given the proprioception work. So when an individual has an injury, proprioception will switch off. So you will get this kind of switching off of knowing where the body is in space because the injury is affecting the messaging. And so that's where balance becomes challenging. And actually balance work can help to start to reprogram that messaging system. I'll come to that in a second, Katie. So the balance work makes sense. It's also really low grade. It's really kind of in the kind of safer end. If you think of interventions in terms of contraindication, strength work is at the higher risk end, even under controlled settings. If you're loading the body when you have pain, dysfunction or problem, it holds more risk. Coming down into balance work, it's lower risk, it's lower contraindication, particularly if there's pain. Are there other techniques that can be done at the front end, which is, I guess, what you're wanting to know at this point when asking this question? Yes, probably. And there's something I want to talk about in a moment. So putting it all together, posture, should I be trying to correct the posture? In my opinion, just trying to stand level, no. That's my opinion. That's my professional opinion. That's an opinion of being an alignment dance queen for many years, where alignment was everything. That's my opinion based on the cadavers I've seen in the medical labs who are physically different, intrinsically from one side to the other. Normally, that's their normal natural position is asymmetrical. And I think there's too much of an emphasis on alignment rather than purely just functioning. And so that's really where the function would be for this individual. The focus would be is rather than purely thinking about trying to stand in a line, particularly if coming into a line feels wonky. What we really need to address here is which parts of this individual's body are not functioning optimally. How can we test them? And then how can we improve that area and then retest it and then monitor it over time. So that would be my standpoint. That's coming from my biomechanics coach training. Is I would take this individual in, I would assess every joint and structure within their body, irrelevant of where they hurt. So even if it's the hip and the back, I would still look at pelvis, spine, shoulders, the nerves, the knees, the feet. I would want to understand the entire system and how it's all contributing to the way this body is functioning. Quite often what we can find is that it's areas of the body that don't hurt that can be the root causes of what's going on. Now, sadly, this individual does have an impingement in the hip. That actually is not uncommon, and there are really basic techniques that can help with that, some of which she's already got, and they are already helping. What we want to identify is, for this individual, how can we provide a long-term solution so that it doesn't come back? And so we want to really develop a maintenance program. And the only way to do that is to identify what else is happening that is causing that hip impingement, that's causing the asymmetry, that's making the spine get scoliosis and the back is sore and the hip is sore, and all of these things. Now, it could well be, and I would suspect, and again, it's just hypothesis, that it's the rest of the body being out of place for a long time for whatever reason that has actually caused the problem in the first place. So my emphasis would not be on the hip and the back, which both hurt. It would be to focus on the rest of the body. By taking pressure off the areas that hurt, I'm staying within my remit. The individual has then confidence in the homework I've given them because I'm asking them to move the bits that don't hurt. And then what we're doing is taking pressure off the areas that hurt while the physios and the therapists work on those areas. So it's really important that we generally as professionals work collectively together, stay within our lane, but actually talk to each other and transfer meaningful information. So I really want to speak to her physio, and I want to understand the detail of the diagnosis. Hip impingement is pretty clear. The question is, why has she got the hip impingement? What does the anterior pelvis tilt mean to you? Why is that caused? Because there are several reasons why you can have a pelvis that is stuck in an anterior tilt, which is how I'm reading this. There isn't just a single causative factor. The right hip is higher than the left, so what's causing that? And then the scoliosis. Now we could maybe argue that it's the QL that started it all. And it may not have been the hip. Maybe because she was carrying her bag over one shoulder, going into the classes and then coming out of the classes, and always going that way, wouldn't it? Always carrying the bag on one side, that the QL on the other side was always jammed up. So actually, what resulted in the hip impingement was caused by a QL that was tight, overactive, in spasm, dysfunctional. And so it may be the scoliosis caused the hip problem. Chances are we'll never know the actual answer to that. She will probably be thinking about that right now and go, oh yeah, where did I carry my back? Did I have a favourite leg? I know the fitness instructors will always demo with the left leg first, and then we very often don't do the right leg when we're doing freestyle classes anyway. And so we've had this habit of generally do the demo leg first always, and then not the other leg because you're cueing other people. So that may have been one of the causative factors. And again, chances are we'll never ever find the actual causes. The individual that's going to know more about this is the client, is the person, it's them themselves. And so I think one of the important things coming out of all of this, and to understand, and I'm going to give some techniques that might be able to help with early phase, low contraindication, intervention stuff for anybody who prescribes exercise or is a manual therapist watching this, to understand that when you really get to the root cause of the question or what you're trying to find out, what we really want to know is, what does an anterior pelvis tilt mean? Why is my hip higher on one side? Why do I have scoliosis? To understand that individual's kind of diagnosis. The sun's come out now, so I'm going to stand there. No, I don't stand there. So we want to piece it all together. So what I always teach to both clients and practitioners is, if we individually become responsible for gathering data on our own bodies, and then we keep it and we collate it and we add to it, then when you go and see somebody like me, you might come see me as a biomechanics coach, and I say to you, tell me your history, and you kind of everything, you can just pass over that file. So normally we would expect the NHS to do this and a GP or a therapist to do this, but actually it's quite hard to pull all that information together. So I always try and encourage a client to start to collate their own medical journal or file. And within it, anything that they get that's a diagnosis from a physio, from a manual therapist, anything they have from a personal trainer, from the GP, to print off or make notes of date and file it in a medical file. This is going to really help any future professionals you go and see when they say, so what did the physio say? What did the MRI show? What did the sports therapist diagnose? And you're like, oh, I can't remember. And so if you've got it all written down, it's very medical, it's all the right terminology, it's going to be super helpful. If somebody came to me with that file, I would be so blown away and excited. That's going to really help me understand better that client's history. It also means that we are taking responsibility for our own bodies. And something I think we should all do, and I'm looking at the people that are in here now, as practitioners, body workers, movement professionals, we should be encouraging individuals to be responsible for their own body. They should not rely on us. We can guide, we can advise, we can suggest, but the real impactful and empowering way we should be practicing is to give the responsibility to the individual. That is going to get more long-term results, and it's the same with a medical file. If they collate that, they feel more ownership, and that's quite empowering, I feel, anyway. So a big part of what I do is collate data, and I'm selling them a full report at the end that they then get. All the assessments I've done, all of the thinking that I've had around it, so they can then take that, pass that on to the next professional. So for this individual, just coming back to the lady with the hip impingement, I would really want to understand what the physio said. I want to follow the trail, what has been tried, what did work, what didn't work. The strength work didn't work. Well, that makes sense to me. Strength works too soon. The balance work is working. Brilliant. That makes sense. It's kind of a lower grade. When you're recovering from an injury, proprioception switches off. So by doing balance work, proprioceptive work, you're starting to regain that messaging, calming the system, the pain messaging down, while getting the treatment or doing the right exercises to help the hip impingement. Are there other techniques we can put into place? Yes, absolutely. I would want to be adding in muscle energy techniques. So the post-contraction sensory discharge techniques that I teach at the 20-20. So 20% effort, hold it for 20 seconds. And I want to be doing that on areas of the body that are not uncomfortable, that they can do that on. A static 20% effort hold, held for 20 seconds is perfectly safe. Even somebody with an injury, and as long as they're doing it on the area of the body that's not uncomfortable. What that does is, again, similar to it is proprioception work, but it's rather than balance work, it's low-grade muscle energy technique that's connecting the brain to muscle messaging, to whatever the word is, I don't want to say refire, sounds quite aggressive, but reconnect how much the brain wants that muscle to apply tone onto that joint to allow them to move with confidence. The other thing, just to touch on here, is duration of recovery, and I think this is absolutely key, is to have patience, and actually the longer it takes to recover, in many cases I think, the longer the recovery will be successful. When it's a fast route to recovery, that can often be a mask and just a pain relief, which is clearly what most people in pain want. But actually taking time to analyse data on the way you move, what helps, what doesn't, over time, can give you a more long-term result and improvement. So right in the beginning, test the whole body, test every joint, test every structure, and you can do that really simply. Basic test, set up a camera if it's on your own body, and just do movements that you want to be able to achieve without pain. Just run through them, and you might stop at the point where it hurts, or you do, you know, individual movements, squatting, rolling down, and maybe thread the needle even. You test movements that are uncomfortable and you film it. And then you do techniques to improve it, the muscle energy techniques, the balance work, the low grade stuff. You have maybe some manual therapy. Then you come back and you redo those movements. If your ranges are improving, if the point at which you hurt has got later, then you know that you're doing the right thing. Any other professional's advice and input is always going to be helpful on any of these things, whether it comes to measuring the body, whether it comes to thinking around what's going on. Collectively, what that can do is actually be more helpful. But I think strongest recommendation is to, before you leave a professional's service, is make their ears bleed with questions. Why do you think that? What's going on? What causes an anterior tilt? What do you think is causing my anterior tilt? Why do you think my hip is higher on one side? What could be causing that? Is my scoliosis structural or functional? The only way, and I know she did confirm this morning, she's not had an X-ray, but that's the only way to objectively measure structural asymmetry is an X-ray. There are simple benchmarks you can use, but in this case, what you could do is lift your top up, camera behind you, sit on a chair, and then side bend and see what your spine looks like. That would be a very simple benchmark. You could look at how well your spine flexes, how well it extends. If there's points at which you get the discomfort, you could add those in as well. Okay, no problem. Yeah, leg length discrepancy is common, and again, in my professional experience, more commonly functional than structural. And so using the MATs and muscle energy techniques around the pelvic area can actually eradicate that. And on QL, the wall glides. Okay, so Katie, where are we on time? Okay. I have cyclospine issues as a result of hyperflexion, hyperextension from being an ex-dancer and gymnast, plus being an ex-dancer professional. Now I have a neuroscientist. Look at you, with a background in biomechanics. After 3 years, medical professionals recognised it wasn't as a result of injuries. So it was more of a biomechanical issue by the sound of it. And I think coming from a dance background myself, and gymnastics is very much hyperextension. It's always in that kind of jamming of the thoracolumbar junction, which over time can result in wear and tear and problems. And so I think keeping an open mind to, I always like to get down to what does the word mean? What does injury mean? What does issue mean? Anterior tilt, what is that? Posture, what is that? And when you really drill down to the question, the words in the questions, even if it's your own question, you can often result in finding answers and solutions. You say, oh yeah, well, what is posture? Posture is just a body position. So actually the question isn't, should I correct my posture? Well, it depends on what you define as posture. Like if you walk around and you feel okay, don't worry about it. You know, if you're walking around or if you're holding a position for a long time, that is not great. Or holding a position for long durations, that is really where posture has a negative effect on the body, rather than a specific posture is a bad one. I hope that makes sense. I'm a fan of, you know, if it feels good and you know, it's helping you towards your goals, go for it. It doesn't matter what Barry looks like or Ethel. If that's how you squat, brilliant. If you don't like the way you squat, or if it hurts, or you have a specific goal and you're not able to do your squat to achieve that goal, then you could start to break down everything that is involved in the squat in your body, improve its function, and then do the squat again. And over time, you can start to work out and tally up all the things that are contributing to your squat both positively and negatively. It's quite a simplistic way of looking at it, and people always think it can be quite complex, and to be fair, you can get very complex when it comes to the body. The body is a fabulous piece of architecture. I mean, it is fascinating because you will never stop learning. If you study anatomy, you'll never stop learning. And by the way, all the people out there that want to know all the anatomy, good luck. It's probably not going to happen, because when you start reading about 5 quads and 6 quads and triple-headed biceps and 6 orientations of the piriformis and the sciatic nerve relationship, you realise that when you get a book, a really, really good book like Trail Guide, one of my favourites, by the way, massive fan, you can see how worn it is, and after 30 years as a fit pro, I still get a book out and analyse areas of the body. I still, cadaver labs, one of the best places to appreciate that this is 2D, and that drawing of that is just one example. It's like this femur on this skeleton is one example. My femur, your femur may not look like that femur. And so when you, there are similarities, obviously, but when you really get in a cadaver lab and look at how different we are on the inside, it is fantastic. It's really exciting. It's how we then interpret that into looking at our clients, putting our hands on our clients when we're massaging them, and how we then, how do I translate what I learned in 2D to a 3D practice dummy, then to 50 clients who are all completely different. And I think one of the biggest problems that practitioners have is blaming themselves for not knowing enough. And you'll never know enough. I think that there's a constant learning process. So you've got to try and get more comfortable with what you do know, but look at what you want to know that you haven't yet studied as much as you want to. You go and you analyse more, you know, get your hand, when we can, obviously, put our hands on people. I'm super tactile. I like to, you know, kind of feel people's joints and palpate scapulars and femurs and backs and things to really enjoy the differences between us. And I think as professionals, when we're out there looking at different bodies, try not to be too hard on yourself when you don't know the answer, because honestly, no one really does. When it comes to the human body who's live, we have no idea what's going on inside that body. A surgeon doesn't know what's going on until they chop you open. They've got a good idea of where things are going to be, roughly. But actually, the minute they chop you open, everything changes. The minute you have an anaesthetic, everything changes. So a live, moving, personal training client in a gym, what's going on inside their body is a lot of hypothesis. It's a lot of guessing. It's a lot of, look, if they move well, if they move okay, if they're comfortable, crack on. Try not to focus too much on the alignment. It's about the function, the enjoyment. Yes, coaching, alignment, movement, a little bit, that's a good kind of barometer or benchmark, if you like, of basics of coaching if they feel awkward or they're doing a movement they've never done before. But then let them just squat the way they want to squat. Let them sort of feel the movement rather than be too, your knee needs to be right here so that it's exactly in line with your second toe. Because for some people, that may not really sit with their hip geometry. So I always realise, get to this point, I take a breath and I think, gosh, what was the original question? So why can or can't some people do thread the needle? So Maria, I think we recognised it, we recognised the hips, the spine and the shoulders are all involved in that position. So taking away the hip and the arm means you can analyse how much they rotate around the spine, taking away the spine and the shoulder and so on, as we said earlier. And then the second question, posture, to correct or not correct, with the diagnosis of hip impingement, anterior tilt. We went through and what we might want to look at to help with a client who's got those issues. Contact the therapist, speak to them, talk to them maybe about, I'd like to work with you, can we, with the client's permission, transfer information between us. Listen, I've had the luxury of a physio and an osteo basically on call for my questions, which they have been quite often in the past, for 16 years. And I do not want to be a physio or osteo, but I need their input. I need their thoughts and advice sometimes. And I've actually learned more probably from just talking and listening to those guys than from some full qualifications that I've got, which are great and give me the insurance. So it's having a balance and understanding that conversations with peers, you know, little CBDs like these live videos, you can pick up nuggets. And I'm also super aware that when I do these, it may result in loads more questions. And if it does, fantastic. That's the point. We should, you know, always have questions, and feel free to post them in Zoom, post them over on Facebook. Let's just have a quick check-in over on Facebook. A few Charlie knows there. Anything you'd suggest regarding movement assessments and MATs would be great. Come and do my education. Andrew Beale. Says Andrew Beale. I appreciate any suggestions reading you may have. Oh, Charlie Mo, I've got loads. May have to ask for a demonstration. Okay, no problem. Any more questions? Just checking on Instagram. The more I learn, the more I realise the more I know, Stevie. It's a bit like that. Okay, so listen, I could do with some questions. I'm about to set my lighting up slightly different next week. I feel like I'm in and out of the light here. So if you've got any questions off the back of that, post them here. If you've got any different questions, send them in. We can do this again next Wednesday, same time, same place, same kind of stuff. He said to me, try and get really specific with your questions. We've done lots of generics. Something really specific would be great. Otherwise, I will make it up as I go along. So, before you go, YouTube channel, Biomechanics Education. All of these free Biomechanics Q&As are all over there from last March. You can go and have a little talk through, see some of the cool stuff we've spoken about. I do free sessions. I'm just putting together a Facebook page that teaches clients and professionals how to use arm 3D techniques on your own body to improve your movement quality, even if you have issues going on. Head on over to biomechanics.com, click on workshops, click on online, and you'll see free stuff, cheap stuff. There's anatomy videos for £7. There's a load of blogs in there as well. Go and fill your boots while we're in lockdown. Let's keep the learning process going and keep moving well and moving more as much as you can anyway, under the current restrictions and limitations. I hope that was helpful, guys. Instagram, see you soon. Thanks for being here. Let's click off there. And now, Facebook will go when I click off Zoom. Guys on Zoom, John, I think sent an email this morning, so hopefully if you're up for that, I'll look forward to that at the end of the month. Otherwise, John Short as well, nice to see you in. Katie, Sharon, Suzanne. Take care, guys. See you on the other side.